Okay, welcome everyone. I see some folks are still connecting to audio, so I'm going to give it another couple seconds here. All right. Welcome to the, believe it or not, 18th Crisis Response Improvement Strategy Committee meeting. It feels like it's been ages since I've seen all of you. I think it's been almost 2 months, but it's nice to be back together again. We're going to dive right into our agenda, but first I have a couple of housekeeping items. First of all, we have ASL interpretation today provided by Lori and Jackie. They will be trading off every 15 minutes, and the person who's doing the interpretation will be pinned to your screen. So if you don't need that, you can go ahead and click on the little 3 dots in the upper right corner of the little window with their face, and you can unpin them from your screen. Let's advance the slides, please. Okay, quick tech reminder, since it's been just a little while. I have 2 slides here, one for CRIS Committee members and one for our members of the public and guests. So CRIS Committee members, first of all, if you could keep your mics on mute, unless you're speaking. And if it is available to you, particularly during the part of our meeting today where we're holding a discussion, which is in the latter half of the meeting after the break, if you could have your video cameras on, that would really help with the facilitation. Obviously, if you're having bandwidth issues or you just can't be on camera today, that is fine. But if you're up for it, please turn on your video cameras. Advance the arrow, please. We use the raise your hand function to indicate if we want to make a comment or ask a question. Click on that reactions button, pops up a window, and then click raise your hand. Advance, please. For chat, if you have a comment that you would like to make in a written form or a question rather than verbal, you can use that chat. Send it to me, Jamie Strauss-Clark. By the way, everyone, I'm sorry, I forgot to say, I'm Jamie Strauss-Clark, your facilitator. Apologies. Send it to Jamie Strauss-Clark, and I will work it into the discussion. If you're having any technical issues, you can send a chat to Brittany Thompson, and she will do her best. There's maybe some issues beyond her control, but she will do her best to help you. And then click ahead, please. If you'd like to see as many CRIS Committee members on the screen as possible, you can click on that speaker view, change to gallery. All right, let's advance the slide, please. All right, this is our second slide. This is for our members of the public. Thank you as ever for being here and taking time out of your day to be part of this process. We appreciate it. Members of the community, if you could please keep your mics on mute for the duration of the meeting, with the exception of the public comment period. If you're called on to make a comment, that would be a time to unmute it. Similarly, if you could keep your video cameras off for the duration of the meeting, except for if you're making a public comment at the end of the meeting. Advance the arrow, please. And again, same suggestion. If you'd like to see as many CRIS Committee members as possible, when there's not slides up, you can click on that speaker view and change to gallery. I think that's it for the etiquette. CRIS Committee members, if you could try to remember when you're speaking today, for the first time that you're speaking, if you could state your name and your representation on the committee, that'll just help our members of the community track who is on today. And then finally, if you are experiencing any unstable internet, you can choose dial-in for audio, and that will help. That typically helps. You can also turn off your video camera, CRIS Committee members. That also helps with internet stability. I think that's it for the housekeeping. So let's move into our welcome and introductions. And I'm going to ask Senator Dhingra to offer some words of welcome. Chloe, if you could take that. Perfect. Thank you. Senator Dhingra.
Thank you so much. Monica Dhingra, State Senator from the 45th District, and I represent the Senate Democratic Caucus on this wonderful task force. I just want to say thank you. I know I say this all the time to all of you, really, for engaging in this work. As I was coming into my office for this meeting, I was just reflecting on where we started. And I remember when this bill came into the Senate and I rearranged the task force. And because I really wanted to make sure that we were being really, really inclusive. And I remember the other legislators, both in the House, actually being very concerned, and other senators saying, there's no way you can have so many people doing this work. Like, it's not going to work. And, I'd spoken to Rep. Orwell, and she and I were together in saying we wanted participation from as many stakeholders as possible, and that we were going to make so many voices being at the table work. And I was just reflecting, so a lot of people did not think we would be successful in the way this was structured. And I will tell you that, yes, we had growing pains, but we are here. And I actually think we have made this work really well. So I want to thank our facilitating team. I want to thank each and every one of you for really showing up with the attitude that you will be working together in getting us to a better outcome. And it really, as I get ready to go into the next legislative session, I cannot tell you how empowered I feel to be able to tell others and tell other task forces that, yes, you can have a very large group. You can hear from people from all walks of life on a particular issue. And yes, we can make it work and deliver great results. So I just want to thank you for continuing to show up and continuing to show up with the intent to get really good work done. And I just cannot tell you how proud I am for everything we have accomplished and will continue to accomplish. So thank you once again for being here.
Thank you so much, Senator Dhingra. It's good. I think it's a good way to kick off our last meeting together of 2023. So thank you for that. We have two new CRIS Committee members that I would like to welcome. I'm going to give them a moment to introduce themselves. Before we do that, I'm going to quickly walk you through our objectives and agenda for today, and then I will queue up Alicia and Connie to introduce themselves. So our objectives for today are, as ever, understand where we've been, where we are now, and where we are going in the CRIS process. We're going to learn about the Department of Health's work on the technology user experience, design process, and outcomes, including their engagement with lived experts. We'll have some time for you to ask questions on the newsletter updates from state agencies, the governor's office, and CRIS members relevant to 988 and behavioral health crisis responsive system improvements. You'll learn about Tribal 2024 behavioral health crisis legislative priorities. And then our discussion today is going to focus on gathering your feedback on the draft recommendations for the progress report to the governor and the legislature. So that'll be the later half of our meeting. Then we'll confirm action items and next steps and hear public comment. So let me just, if you can advance the slide, I'll just walk you through the timing on this. All right, so we're getting through this welcome introductions and meeting agenda. We're going to have our personal story at 12:20. And then at 12:40, that will be system updates and agency Q&A. So that's when we're going to hear from Department of Health on their technology work and engagement with lived experts, and have some time for you to ask some questions. We're aiming for a break at 1:20. And when we come back at 1:30, we're going to start our discussion, getting your feedback on the recommendations for the progress report. At 2:45, we'll move into action items and next steps. And then if we get any signups for public comment, we'll just start public comment at 2:48. And I forgot to mention, folks, if you, members of the community, if you would like to make a public comment today, please send a chat to Brittany Thompson. We'll take you in the order in which we receive your request to make a public comment. Please also let us know if you need any accommodations for that comment. I'm going to allow 2 minutes if we have that time, if we don't have too many people signed up. If you need more time than that, please indicate that in your chat. All right, let's take down the slides for a moment because I would like to welcome our two new committee members. We have Connie Chapman, who's representing veterans organizations. And then we have Alicia Morales, who's representing first responders with a CARES program. So I'm going to invite Alicia to introduce herself, and then Connie. Alicia, welcome.
Hello, thank you all. My name is Alicia Morales, as Jamie mentioned, and I am with the City of Tacoma Fire Department. I use she, her pronouns, and I'm a Mexican and Black bisexual woman with lived experience supporting people through the crisis system, as well as utilizing the crisis system and receiving services. I currently co-manage a alternative response program called the HOPE program, stands for Holistic Outreach Promoting Engagement, and it goes out into the community and supports not only the community and first responders, but it offers an alternative approach to people who are experiencing behavioral health, mental health, or substance use crisis. And the team is made up of a mobile unit registered nurse and nurses, we have two, and behavioral health crisis responders who are MHP as defined by Department of Health, and then a behavioral health case manager who provide community-based and office-based preventative in the moment and follow-up outreach. And just to give some other information about myself, my approach is really to listen and observe and to learn before I provide any type of response or I share anything if it's appropriate to do so. And language is very important. And so I do my best to know better so that I can do better. And I really appreciate the opportunity to be a part of the CRIS Committee and to learn and to listen from all of you. And I hope that my experiences can support the committee. Thank you.
Welcome, Alicia. We are so thrilled to have you part of this committee and all of the expertise and experience that you bring. And speaking of great expertise and experience, I also want to introduce our other new committee member, Connie Chapman. Connie, welcome. Oh, Connie, we're having a little trouble hearing you. I don't know if your mic is pointed away from your mouth.
Is this better?
Yes, that's perfect. Thank you.
Okay, so my name's Connie Chapman. I'm a licensed clinical social worker and certified case manager. I am the suicide prevention program manager for the Washington State Department of Veterans Affairs. I'm also a retired combat veteran. I have experience in suicide prevention and working with veterans for over several years. I also saw that Dr. Small is on this committee, and Dr. Small and I worked together at Primera before. I worked there for 9 years. So
That's a fun intersection.
Yep.
Thank you, Connie. And again, we're just so thrilled to have both of our new members. This is really good timing as we dive into we get prepared for a big 2024. And speaking of that, that's a nice segue. Betsy's going to walk us through where we are in our process with a particular focus on how we're going to get this process of getting our annual progress report to the governor and legislature wrapped up and out the door. So Chloe, if you could put those slides back up, I think Betsy's going to walk us through that.
Thanks, Jamie. I'm Betsy Jones with Health Management Associates. I'm leading the team that is working on this initiative, facilitating the advisory group and the subcommittees, as well as the steering committee, working with Jamie and a large HMA team for those of you who don't know me. So glad to see you all this afternoon. Usually I talk about our decision process, so where we've been and where we're going. I'm going to drill down a little bit today and talk about our next steps to review and approve our January 2024 committee progress report, which is the bulk of the work that we'll be doing today in discussion. So we're here today on November 7th to, as I mentioned, review and provide feedback on our draft 2023 committee recommendations. As a reminder, these recommendations are the foundation of the committee progress report that's being submitted. And so you'll see in our final report, our final progress report, the recommendations that you're reviewing today in, largely the same form. So it's, really important that that the work that we've been doing all through the summer, and especially in September in our in-person meeting, those recommendations will be very much reflected in the report that you'll see in January. On November 13th, you will be receiving the draft report to provide review and feedback on. There are about 3 weeks allocated for that review and feedback by both the CRIS and the steering committee. And then on December 11th, the steering committee will receive the final draft report for review and then approval, ideally on December 18th. And on December 22nd, we will submit the final report to the governor and the legislature. And just a note that we did not have a November steering committee meeting because we wanted to give steering committee members the time today to really listen and hear from you all in terms of your recommendations, and give them then the additional time to review the report before it becomes final. So steering committee is really listening and will be incorporating your thoughts in their review of the report that will be submitted on December 22nd. That's what I have for you today.
Okay, great. Thank you. So I think that takes us now. We're through with our initial agenda item. Again, just a reminder to community members, if you would like to make a public comment today, please send a chat to Brittany Thompson and also let her know if there's any accommodations you need. I will take as many comments as we can in the order we receive them in the time we have allocated. If we get a lot of interest in making public comment, I might shorten the time from 2 minutes per comment to 90 seconds, but we'll make that call as we get later in the meeting and see what the list looks like. And with that, I am going to turn it over to our CRIS committee member, Vipasha Mukherjee, who leads Lived Experience Subcommittee and organizes our personal stories, to introduce today's personal story. Vipasha.
Thanks, everybody. Can you see me? Okay, I'm in a hotel lobby, so if there's background noise, please forgive me. My name is Vipasha. I'm on the lived experience. I'm on the CRIS as a person with lived experience. And it is my pleasure to introduce you all to my friend and co-worker, Puck. The two of us have been at this since the get from September of 2021. Puck and I have a relationship, I think, that is very meaningful to me. We bring same and different approaches to this work. I want to highlight the differences because it helps me expand my thinking and approach to do this work rather than being stuck only in my head. They're always grounding me in what the system does to persons with lived experience that I personally can be blind to. I have over the months deeply appreciated Puck's vulnerability and how open they are in talking about their own journey and in real time. And I want to emphasize the real time because it's always easier to talk about something that's happened in the past. Usually we've had time to process it and feel less tender and vulnerable. But to speak of what you are living through in the here and now is a different ballgame. And it has been saddening, maddening, frustrating to me to hear about Puck's journey. Last week, when another crisis issue surfaced, I shared with Puck that their story now is exactly what we need to hear. I would like us to keep in mind that we ask persons with lived experience to share so we can be better informed on how to build out a strong, equitable, and just system. But 988 is officially live and active. And we hear on how it's not going so well for some callers. You'll hear more from Puck about that. And this is not just about the phone centers, but about the entire continuum. We mind their stories, but it poses a bit of a moral dilemma to me as to what we are or can do to support people now. Crises don't wait till everything is in place. So here's Puck sharing with us something they're navigating every day, yesterday, today, tomorrow. And it is my request to you all to listen to their story in terms of the future build out, but also on what do we do to help people now. Take it away, Puck.
I think you're on mute, Puck. There you go.
Can you hear me all right now? Okay, sorry for being quiet. We are in the library. Last time I checked in with you, I was living in Yakima. I was living in a 5-bedroom house with my spouse, and throughout the CRIS process, I have left that marriage, and I am trying to live in Seattle, and wow, it's really hard to do as a disabled person who doesn't look like a traditional disabled person, but I'm autistic, I have ADHD, I can't get a place every day, I can't do a job, I can't follow through. Bipasha can attest, like we all have times when we can do stuff and we all have times when we can't do stuff in terms of the lived experience crew here. So yeah, it's a whole different story. That's not even why I'm here. Why I'm here, I moved into a co-op because that's the most affordable option. And this one, Sean moved in also, and he was new, he was sweet, he drank a lot. He ended up leaving the co-op largely because of his alcohol use. We spent, gosh, it was what, 5 or 6 months with you living in an SRO hotel, mainly doing some couch surfing while he drank and cycles. Last September, this past September, he finally was like, hey, I might want to stop this cycle. And I was like, cool, that's what I do. I support people in this. So I reached out to Bipasha because I didn't know where to start. It was substance abuse, which like technically isn't 988, but absolutely is 988. We think a lot about mental health crisis. I would argue that most substance abuse also involves mental health crisis. So called Bipasha to see where to start, and we thought maybe he'd have better luck. Maybe he'd have an easier time getting a bed because it was substance abuse rather than just mental health. So we called it might be easy to write it off as not mental health, so out of scope, but I feel like it still falls under the purview of crisis. That's why we're going into detail about this today. So that was September 12th, and Bipasha had me call the Washington Recovery Hotline, and they gave us a list of different places to call for potential inpatient. We called them, lots of runaround. Someone said to call 988 for a referral. 988 was confused about that. We talked to so many people. Finally, we called the helpline back and got an SUD assessment scheduled for the 14th. So on the 13th, he was packing. He was thinking, yeah, I'll do some kind of rehab. It'll be good. On the 14th, Harborview canceled that assessment, saying they had too many appointments. We did some more research on potential locations. I have 12 listed on my little notes that I took during the time, but no first steps. He said it was okay to go out to Seattle. He said his main priority was this actually being a valuable experience, so he didn't care where it was. At this point, like I'm still doing the planning, but I feel pretty cool about the fact that he's about to get going on engagement in that process, which to me shows that this is a person who is actually committed to his recovery. So we had a lot more runaround, scheduled an assessment, said, I have notes here from him that say the inpatient place they transferred me to is impossible to get to a human or voicemail, but says they take walk-in admissions Monday through Friday. Instead of that, since he had an assessment scheduled, we ended up doing that assessment, and he called, confirmed coverage with his insurance. He did all the due diligence of someone who really wanted to do the thing. It was the weekend. He didn't drink. He stopped doing his job because his job was literally working on an app to prepare, to train people on how to serve alcohol. So not really a good fit there. At this point, he has exhausted all his money, which sucks, but also means he can't buy more alcohol, which is a good support here. So the 16th, he was sold on this one center, but he still needed to do the assessment. And he said they'll fax the results to them. They'll get back to me in a few days. So he's getting back. He's handling the logistics. I have a message that says, I'm 100% in this now. And I asked, what if you don't get into that program? And he was like, then I'll find a different one. I'm like, okay, we're still on the right path here. So the 17th, we had a kind of goodbye-ish dinner because there was an intake and we thought you were moving forward. And then from there, you had your first case management appointment on the 20th. We're moving from what I've written down to what I'm trying to remember because I haven't had the capacity to write through all of this. So from there, you were told, we probably spent, 2 weeks maybe waiting for the records to get faxed. And then we were told that you hadn't done the right assessment at that intake. And so I think about here, you've moved in with your friend, you're sleeping on his couch, And at some point, it was for some reason he couldn't go to this other organization's program, and he was going to instead do an inpatient here. And so from there, it was several weeks, wasn't it, waiting for you to get a bed in the inpatient?
So total, the span of time here is getting a little hard to keep track of, but total from start to getting me into inpatient was about 6 weeks. Finding out who to talk to, getting the assessment done, waiting for the assessment to be faxed over to the facility I was planning on going to, then finding out that the incorrect assessment was done.
We tried to go like another place to do a different assessment, but they said we couldn't do it because it wouldn't be covered out of county or something. The organization he was in said we can't do another intake, even though we did the wrong assessment. We can't do the right assessment. It was all a bunch of absurdity.
And my case manager also was very emphatic eventually that they did not do SUD assessments, and is now telling me that they do. It's all very strange, but once I got into inpatient.
Okay, so we got shown into inpatient.
Yeah.
It was amazing. We did another going away dinner. We were very excited. I got home and was like, oh, I can focus on my life and try to work on dealing with my stuff. And then the next day I was on a meeting with Vipasha and planning our next lived experience group, and I got a call, and it was his first day. Like, he'd been there one night. It was the next day. They're telling me, he's afraid to tell me because he thinks I'm going to think he fucked around and like is just trying to get out of the program, right? So he puts me on the phone with a counselor who says, no, we did our substance use assessment, and because he has not drank in 6 weeks, the 6 weeks he's waiting to get into this program, he is not eligible for this program. And I cried and I yelled, and he's homeless now because his friend whose couch he was sleeping on, that friend's house is falling apart. And so he has moved his office so we can tear the walls down to try to fix the office. So that's all on the couch. So I told the counselor, I was like, he has nowhere to go. And the counselor was like, yeah, everyone who comes in here basically is homeless and leaves homeless, which is not acceptable. You can't put someone through a sobriety program and then leave them homeless. That's not okay. We asked if there was a housing person we could talk to, and he chuckled. I'm sure it was a, oh God, this is awkward chuckle, but it was a chuckle, and said that the guy was inside and we were outside, so he couldn't talk to him. So now we're here. We stayed in the hotel the first night. We called 988.
Yeah.
I can't count. I meant to count how many people we've called to try to find just shelter, to try to find transitional housing for him.
Yeah, so we called 988 a few times. We called 211. We've got the Emerald City Resource Guide
We've
here.
called everyone in that is relevant for him multiple times.
And sadly, a lot of the folks that we end up calling end up referring us to places that we've already called.
Or 211 or 988.
They'll list off, all the different places that we've called. Pretty much all the shelters that we contacted were full. There was no availability. I did eventually end up physically walking into Indian Center down near, I guess, just north of the stadium. And they processed me pretty quickly. And I was able to then go across town to the actual shelter and walk in. And so that's where I'm currently staying.
We've driven so many places.
Yeah.
There's something about regional connectors or something where you're supposed to be able to go and do an intake with someone, but none of those places are walk-in because of COVID. And we called and left messages and it doesn't work. And it's the most disheartening process for us. I can imagine it's a really incredibly disheartening process for all the people who have to turn us away all the time. I have a car. It just broke down. Of course, everything is terrible right now. I can't imagine doing this process without a car. I just want to hold every legislator's hand and walk through this process with them because we've tried. It's been at least 10 hours we've spent trying to find shelter. right now he's looking at the Union Gospel Mission Program and like, we're gay. He's not religious, but that feels like the best option. And to me, that feels predatory. It's a year-long program where they're going to teach him about Jesus, and that's the only option that he has that makes any sense right now. And that's predatory. I can see people being litigious about that being their only option, because we shouldn't have to access these services through the gate of a religious institution that is trying to convert him.
And I'll speak to the shelter that I'm currently at. So the reason why I'm still looking into shelters and housing is because the current one isn't exactly the best. So I'm in Queen Anne. It's 80 something people in the shelter. It's one big room with a bunch of bunk beds, which I understand is very common. But there's one bathroom, and of the 3 showers, only one of them works. It's cold, and there's no curtain. I don't understand how that's supposed to work. Fortunately, I have friends whose houses I can go to in the wee hours of the morning and just use the shower and leave. But I also don't feel incredibly safe there. I deal with PTSD, and just living in an apartment by myself with a locked door, I sometimes feel unsafe. Living in a one big room where the lights never turn off, and I'm just on a bunk bed out in the open with my backpack, and I constantly am anxious about my safety and my belongings. So that's why I'm still looking into other housing. Oxford House is currently my what I'm shooting for, which is sober housing.
So yeah, it's been hellish to watch someone I care about go through this process. And it's been incredibly hard for my mom and my grandmother, who are like, we wish we knew how to help, but we don't know how to help. I would love him to have some stability. Grants for the Oxfords don't come. He wouldn't get a place there till December. I'm like, could we fundraise money to pay for him to get in an Oxford House earlier so that he was able to have that structure and stability? No, we can't do that. He won't be eligible if he has someone pay for his initial time. We could, it's all incredibly enraging. So yeah, that's our report from the field. That's all I got. Thanks for your time and your patience.
Huck and Sean, thank you. Sorry, there's a lot of background noise, but thank you so much for sharing your story. As you are going through this in real time, Huck, who has to navigate their own life and is supporting Sean. I was there in that meeting when Huck said, I have to take this call, and came back weeping that they have to go pick up Sean right now. This is not a new story to me on the regional crisis line where I answer calls of King County operated by Crisis Connections. Families and folks get the runaround. I don't know how often I hang up angry that we don't do better for people. My heart hurts for callers. I would like to help them, but I don't know how. And folks, the devil's in the details, as they say. We've done important work, and I don't want to take away from that, because we need that foundation that we can do good work. And we really need to know how things are for people and why people may not trust the system when the system is so difficult and they are struggling. Also, I just want to say, who is the system built for? Perfect human beings in crisis? That's not how we function. Anyone who's interacted with folks with lived experience or have lived experience themselves know that there is usually a window of opportunity to get help. And the system has to be present when that window is open, and people should not be waiting for when the system is ready to offer them help. It's honestly silly to say, you've managed to stay sober for so long, so you don't qualify. I mean, it just makes no sense. We can't have a crisis response system that needs people to be in dire crisis to be eligible for care. If we're really to build a good system, we have to ensure the entire spectrum of human needs is being considered. If we are to move people out of the crisis system into a more stable life, as we say, housing is behavioral health, transportation is behavioral health, healthcare is behavioral health. It has to all be done simultaneously. I know it's a hard ask, but we're asking for it. So I'm going to get off my soapbox here. And thank you, Park. Thank you, Sean. Much, much gratitude.
I want to say, take a moment as well, but before I do, I think Senator Dhingra has some words to share.
Thank you. Thank you, Sean and Puck, for sharing. And I know normally we don't tend to respond to the personal stories because it's hard many times to do so. But since this is happening in real time, I wish I could tell you I haven't heard the scenario before. It's unfortunately common. I also want you to know because there are many in the legislature who know about this. Not everyone does. And so it's important that these stories be told. And unfortunately, it's also important that they be told over and over and over again to different audiences. I want you to know that the stories and your experiences that you share do have an impact. And when I look around the room, the virtual room, I see people who can actually take action on these stories, and there will be. We made $1 billion in investment in housing last session. And for people who think about, wow, $1 billion, I just want you to know that given the need that is out there, that is a drop in the bucket. That the data that we have on the amount of need and what it's going to take to actually provide a home for everyone, an affordable home for everyone, a place where they can go, is so tremendous that we have to kind of continue working on it. And so it's these stories that when we go back to the legislature, we want more resources, more support. And some people go, well, you only got $1 billion last session. How much more do you want? It's these stories that help us say, we know firsthand experience that this is not enough. It's not even close to being enough. So I just want to say, we hear you. Thank you for sharing. And I'm sorry to say, but you'll be called upon over and over again to share more.
Thank you, Senator Dhingra. Sean, Puck, thank you for coming today in the midst of all this and sharing your experience with us. I think I'm watching folks' faces, and it's clearly affecting your fellow CRIS committee members to hear the actual stories. Puck, you've been a voice this whole time for addressing immediate concerns, and I'm so sorry that you both have to go through this. And I hope that fortunes turn soon and quickly. And Sean, I admire you so much in your commitment to recovery. So thank you. Thank you so much. I know this was really, really hard. It always feels very strange to move back into business after this, but I guess that's my job. So let's go into our updates. We're going to start. I'm just going to walk you through how we're going to do this today. We're going to start with a presentation from folks at Department of Health. I think Elena Perry is going to be the one sharing the outcomes from the technology user experience design process. And then Vicki Lowe and Catherine Akia with the Indian Health Commission are going to be, American Indian Health Commission are going to be joining us around 1 o'clock. And they're going to present on the tribal 2024 legislative priorities. And then when we're done with that, we'll go into Q&A for all of the content, including what you've picked up from the newsletter. So with that, I'm going to turn it over to Elena, and I think Chloe's going to put up some slides. Elena, thank you for being here.
Yeah, thank you all so much for having me. And for those who I haven't met just yet, my name is Elena Perry. I use they and she pronouns, and I'm the 988 program supervisor. at the Washington State Department of Health. And what I'm here to talk to you all about is a joint effort from the Healthcare Authority and the Washington State Department of Health, DOH, to highlight user experience insights and how they're going to be interactive with and supportive of our request for proposals for the larger tech platform that we've been tasked with building out. Go to the next slide. I am just the programs person representing an amazing team across HCA and DOH, including Sachin Landy, Eric Brace, Beth Shermans, Maddie Cope, and Bridget Doyle. And go to the next slide. This initiative might be new to some of you, so we'll walk through some updates around what this request for proposals is for. And the reason that we're here to share it with you is not just to tell you, here's what this tech platform is looking like or is shaping up to look like, but even myself as a programs person, someone with lived experience and someone who has navigated these systems and supported these systems, been on both sides. We got some amazing insights from this work that we think can help everyone here on the CRIS Committee and help our partners in all of our programs. We can go to the next slide. So I'll cover a background on what's happening in this pre-request for proposal phase. And then we'll discuss some of the deliverables, what's coming out of this phase. And then I want to walk you all through the amazing amount of engagement we had with our local experts and folks with lived experience to get to know their experiences of the 988 system and how it interacts with technology. And then we'll walk through refinements and system requirements, as well as user stories. And I'll define all those things really soon. We'll give you time for questions and comments, and just to note that we'll keep additional information in the appendix of these slides that are accessible to you all that we can reference during today's presentation if anything arises, or you can just take a look at later on to get further information. All right, next slide. So we have been tasked with building out a technology platform that will accommodate the 988 system's mental health crisis calls, texts, and chats. It's to improve our current technology system and expanded services that were in House Bill 1477 and 1134. And I'll say, as a programs person who's joined this team of wonderful change managers and tech people, what does this mean for users, for folks calling in, help seeking, or the call takers and their supervisors? This would mean changes like supporting folks in crisis by being able to improve warm transfers so that someone isn't having that experience of repeating their story over and over and over again, you might be familiar with, or helping our call takers and counselors navigate resources much more easily than they currently do. So this pre-RFP phase, pre-request for proposals phase, is when an agency conducts research, analyzes data, and prepares the requirements for the system. And we've done so by engaging users, people who are going to be the end users of this tech system, so that we can write this request for proposals, select a vendor, and build a tech platform that helps not just the programs folks, but also the people who are actually engaging with the systems, those taking calls, supervising, and then help seekers themselves. So to get to this point, what we've done so far is we spent many hours in workshops with 988 Lifeline Crisis Center staff, not just leadership. Specifically, we were able to connect with call takers and supervisors and shift leads, and also same kind of thing. We did that with each of the 3 centers, and then one specific session for the Native and Strong Lifeline. Then we brought this material also to the CRIS Lived Experience Subcommittee to get additional feedback and input. And then in those gatherings, we collected this feedback, we listened, we learned, and we amalgamated all that information, pulled it all together to make sure that we had common understandings, so that we can have both the requirements on the front end look like what the user's needs and then needs are, and then once we've developed the systems, have a way for our vendors, the people who will actually be doing the coding, creating tech system, to be able to check this work and make sure that what they're making works well for the users. All right. So next slide. So what are we developing to guide this work? We've developed so far 5 user experience profiles, and in the tech world, they call those personas. They've been drafted and they're going to continue to be refined. Those user experience profiles, like I said, will be used to help us craft the system and then test the system on the back end. We also have come up with, from these experiences, over 500 systems requirements, things that we need the system to be able to do. And we incorporated data from this experiential data we've collected here to bring into the consideration of those system requirements. Then we'll develop out user stories that translate the lived experiences of these people into user voice that's actionable to build into the system's architecture. So it's exactly the translation we're hoping to do here in the CRIS, of taking what people are experiencing and finding actionable ways of putting it into practice. You can go to the next slide. So in this presentation, we're not able to cover the hours and hours of qualitative data that we gathered. So we wanted to give you insights, user experience insights across some core themes. We've decided to pull out common themes that emerged, insights that were specific to crisis center staff, 988 Lifeline crisis center staff, insights specific to help seekers, revisions that we've made to our written systems requirements, and insights where improvements depend on partnerships outside of the agency's control. We'll move us into the first one. So we can go to the next slide. This is kind of a list. I think it's just in alphabetical order, so it's not in any numerical or focal order, but these are the 5 top most common concerns related to 988 Lifeline Center staff that we heard from these workshops and partner engagement. These we consider areas of opportunity. One was challenges with data and reporting, coming out with concise and clear data from experiences that they're having with callers or help seekers using text and chat is difficult. It's a pain point for them. Another is diversion or warm transfers between 988 and then other systems like 211 and 911. We'll go into that a little bit more soon. Another challenge was on something we've talked about here in the CRIS and in legislation around geolocation, geo-routing, and geofencing considerations. And just for context, that's about the current system when you call 988 routes based on your area code. And we know that that's, I'm from Washington, D.C. So my area code would route me back to Washington, D.C. Geo-routing or geofencing would help kind of create a regional location, a regional pinpoint for me without giving anyone my precise location, versus geolocation would give someone a precise location. Those things don't currently exist for 988. Another challenge or area of opportunity is around staff capacity and training, and then systems navigation and accessibility. So these are our common concerns for Lifeline staff. We'll expand on a few of them in a bit. The next one, we can go to the next slide, are areas of opportunity we learned about in these workshops from our help seekers. Demographic specific support or identity or community specific support arose. We have some community specific support for example, the Native and Strong Lifeline for Alaskan Indians and Native Americans, but for other communities other than that, LGBTQ youth subnetwork, there are other identity-based groups who feel that having additional support specific to their community or identity would be helpful. Challenges with diversion. I think we just heard this in Puck's example being bounced between a number of different agencies, or in this case, phone numbers from potentially 988, 911, and 211. And the challenges that exist in once you've reached one to the other, that need to reiterate your story or repeat what you're already going through. Another challenge is related to seeking emotional supports and coping skills when contacting 988. That's a theme that's another area of opportunity already happening in practice. And then fears or hesitancy around contacting the 988 Lifeline. There are many aspects of this that we've talked about here in the CRIS and in our subcommittees. We'll talk about a few of them later on today. here as well. But that's just a persistent area of opportunity or a common concern for this group. Resources, additional resources needed beyond what's currently in practice available to our help seekers. And I'll talk a little bit more about some of those soon. And same thing as the callers, there's a concern around systems navigation and accessibility challenges when navigating this system. There are challenges specific to third-party callers and for those who are youth or are calling on behalf of youth. You can go to the next slide. So here are some specific personal insights. These are things that helped us not just understand the way that we need to inform our tech platform, but helped us understand how the system works now and ways that we can improve. Warm transfers from 988, currently in practice to, for example, 911, are extremely staff and time consuming. So we even heard of an example where someone who had requested, was on a 988 call, a help seeker had requested support, in-person support from EMS as they were having and experiencing an overdose. And that interaction took 3 staff members at one crisis center to support that need, that ask from the help seeker. Daily work experiences that are challenging for some of these folks are that they have to open up, sometimes up to 6 or 7 tabs of multiple systems to be able to help one caller. And that can be challenging for a number of reasons and hard to track. There's also a lack of a consistent, accessible, easy access and updated resource directory. That can be challenging to deliver effective care. Our centers have done a wonderful job of collecting what resources are currently available, but as we all know, these may have, just like Puck had mentioned, they may have different requirements, different hours of operations, different populations that they're aimed for, and that can be complicated to guide someone through. A number of factors could also impact our training modalities in the future. For example, there are variations on the types and volumes of calls that our centers get. And I'll talk about one of those later on around swing shifts. Crisis management systems, they need to be accessible. I think we've talked about accessibility for tech and for callers or help seekers, but we haven't had as much of a focus on accessibility for staff that might require accommodations so that they can do this work as it should be accessible to all. A lack of consistent feedback mechanism for help seeker experience. That's something that we talk about here and why we really value that storytelling and sharing of experience in this setting. But we know that there's not one place that folks can just provide comment or feedback after they've had a 988 experience. And that's a challenge for quality improvement and quality assurance. All right, you can go to the next slide. So I think I mentioned I would delve into some of these specific concerns or user experience insights from help seekers. And here's some that I just want to make sure we communicate to this group. We know our help seekers are continuing to have challenges around privacy concerns. They might be hesitant to call 988. And some of those concerns are specific to different community groups or demographics. So we've listed a few here. What we heard in these groups is that veterans may be especially concerned about anonymity, and that might make them more drawn to call 988 rather than choosing other resources that might require identification or self-identification. Folks in rural areas expressed concern around potential peer identification by a call taker. And that was also a shared experience across those in healthcare, behavioral health, and law enforcement. There is also an uptick or a noticeable trend in the increase in calls that involve relationship issues and or domestic violence. And we noticed anecdotally an increase in calls from LGBTQIA+ to S+ folks asking for support strategies on behalf of their partners. So really getting down to the understanding of what creates that concern around privacy is helpful because it differs so much person to person. And another kind of important insight that's also a demographic level or community level concern, not related to privacy, is that our Native and Strong Lifeline staff shared that a lot of their help seekers struggle with a lack of cultural connection due to a deteriorating societal support, and that motivates them to call 988. So their needs might look a little different. Another kind of point to a difference or an experience insight is around the way that folks access 988. We learned that chat and text conversations often take more time than voice calls. And we heard a continued frustration with the interactive voice response, or the IVR. And for folks who are unfamiliar with that term, it's just when you call 988, apologies, 988, you are prompted with music and with hearing 4 options to get those specific lines: Native and Strong, Spanish-speaking line, the LGBTQ youth subnetwork, and the veteran lines. And waiting for someone who's in crisis, waiting to talk to a real person and having to sit through that IVR can be extremely painful and frustrating and lead to them abandoning the call entirely. Okay. We'll go into the next slide. So, like I said, some of these lessons learned, I'm not covering nearly all of them today, can be integrated into our tech work. So here are some that we're already integrating to our requirements, or our systems requirements, what we need that system's overall tech platform to do. We need this tech platform to adequately incorporate tribal data sovereignty. We need to make sure that there's expectation setting around what we mean by accessibility. We also need to consider, these are 2 tech terms that our team has helped me to understand a little bit more, but cut over, meaning the time when you transfer from one system to another, getting a new tech platform up, and stabilization, which is when you might see a decline in productivity. So the team is taking on a new technology system, and it might lead to, it takes some time to adapt to. So we have to mitigate that. We have to expect that and mitigate that. We also need to consider that there are some things we can do around warm transfer specific to our system's capabilities, like being able to share reports between a 988 call taker or counselor and then a mobile unit that is sent to that very same person on that very same day, to limit someone's need to repeat themselves, repeat their story. But there's also a training need around warm transfers to support persons who need to go from that 988 line to specifically for 911. We also heard a need for improvements to quality assurance for crisis center supervisors. And we know that peer shadowing, peer call shadowing is really an important part of counselor training. And so making sure that that's accessible for voice, text, and chat would be something that needs to be integrated. We also want to make sure that our system streamlines capabilities that prompt adequate guidance of resources for help seekers. Let's go to the next slide. Here, this is a really important part of today's presentation. If you take away one thing from today, I hope it's on this slide and I hope it's related to your work. We need additional partnerships to achieve some of the goals of our overall behavioral health crisis care continuum. Some of them are featured here. I think Bipasha just said, housing is a behavioral health issue. Some of what folks call 988 for, 988 offers crisis counseling for someone in need of care. It does not offer easy access to housing or food. Lots of folks call in for those needs and for things like social isolation, financial hardship, assistance with Social Security, and transportation. So those other systems that promote this need to continue to be improved and be connected to this existing 988 work. We had a very specific ask from swing shift call takers. That's the shift between day and night. So I think mostly in general runs around 4 p.m. to 12 a.m. around the need for more overnight rehab supports for weekends. We also heard that many folks call in seeking inpatient care, hoping that 988 can expedite that process. We know that's not always the case due to accessibility, so that's another big area of growth. And then we also heard challenges around folks who are parents or other caregivers, not just of youth, but also of adult dependents, who are looking towards improving the timing around mobile response in a crisis. We've also got third-party help seekers who are contacting 988 for another line, looking to learn more about how they can continuously support their loved one, which is great, and that can be supported by 988. but in the long term requires a lot more social support to not just, educate and train folks on things like mental health first aid, but to expand access to understandings of this system, was coordinating and navigating through this system that, we don't learn in traditional ways and aren't easily accessible via Google. There's also a systems-wide gap that our call takers had around supports for children aged 4 to 12. And I know I'm short on time, so I'll wrap this up and leave time for Q&A, but the next slide is just what we're doing with this work. These user experience profiles, or personas in the tech world, are complete, but going through some ongoing refinement with new discovery of user experiences, and they're being integrated into this request for proposals that will be forming this tech platform. And so are the systems requirements that will be worked on all the way through February of 2024. And then user stories are going to be developed and are starting to be developed now, so that we can create the narrative or the written part of the request for proposal, really so that we can take what we've learned and make sure we're accountable to it in the system we create. So to wrap this up, go to the last slide, next slide. We learned quite a good deal, and this pre-request for proposal user experience insights, they really make that request for proposal possible. And really, because we have thousands of help seekers, we don't have one unified way of collecting feedback. This lived experience and local expertise that we have gathered through this process was invaluable to our agency's understanding of the current state challenges and how we can address some of them, and how we can work with partners to address all of them. And then the other thing to note is just that we are working, if DOH and HCA are working together to draft, to work on an appropriate request for proposal approach and select vendors for this tech platform. But I know that was a lot, so I'm going to leave us for questions and comments, and just note that I'll put my email in the chat as well if your question has to go unanswered today. Thank you so much for letting us share this work with you all.
Thank you so much. We're going to move into our presentation from Vicki and Catherine, but I don't see Vicki's name on. She was available after 1, so she might still need a few minutes to join us. So why don't we take a few minutes now to ask questions about what you heard today from Elena, and then about 1:10 we'll check in and see if Vicki and Catherine are ready to present the tribal 2024 legislative priorities. So CRIS Committee members, any questions? I'm going to put something in the chat that I got from Sean and Puck. CRIS Committee members, any questions? Oh, I see Vicki too. Any questions for Elena before we move over to the tribal legislative priorities? You can raise your hand if you have a question or post it in the chat. Give folks a minute here. Chloe, if you could take down the slides too, that would be great. Then I can see folks better. Thank you.
Is it all right, Jamie, if I read out the, oh, I see, she has a hand.
Oh yeah, we have a question from Kashi, and then Elena would love to hear your other remarks. Kashi.
Thank you. I'm the youth voice on this group, so I'm always going to have something to say related to youth, and I appreciate that you have noted the need for more services and supports for children, and I appreciate too that one of the things you're calling out is ways to get callers the guidance and resources they need specific to their needs. And for youth, I think this is really important. So my ask would be that any of the personas created, that we have an equal number of youth and adult personas created, so that we can, one youth voice or story example is not going to be adequate given the way that the landscape of resources changes at 13 and the varying presentations among children and youth. So more a request than a question. Thank you.
Thanks, Kashi.
Yeah, thank you.
Go ahead.
I just wanted to highlight that I know that there were at least 3 in process that were specific to youth, and then 1 of the third-party caller ones. So I'll make sure that I communicate that feedback as well.
Elena, did you have anything else? It sounded like you had something else you wanted to add.
Oh, I just wanted to respond to the chat to say it says from Sean and Puck, we were discussing that what would have been helpful from 98, and the answer was informed response. It seems like right now people are just reading off a list of resources, and that isn't enough. And that is something that I think call takers, just like what Puck is saying, what Sean and Puck are saying, our call takers, are acknowledging exactly that there, is a lack of resources, and that they are not, they aren't the ticket to a faster intake into inpatient care. And that is the reality of the current system, that they're, connecting folks to potentially mobile response or 911, but otherwise the list of resources or offering of resources is not much better than what folks can accomplish on their own today. Is to help people through that current state, and that is an ongoing challenge, and something that we're looking to our partners and internally and with HCA to try and improve. It's definitely, that is exactly the current state, and it is a challenge.
I see, Puck, you're raising your hand there. Go ahead, please. No, Puck, we can't hear you. I'm sorry. If you want to throw it in the chat, I'll go ahead and read it out. I know it's a little hard when you're in the library. Other questions or thoughts from our CRIS committee members? Elena, thank you so much for walking us through your process today, and for taking the time to answer folks' questions. If they have follow-up questions, can we pass those along to you? Wonderful, thank you. So CRIS committee members, if you have any follow-up questions that you'd like to ask or you think of later, please send them along to Nicola, and we'll get those to Elena. And thanks again for your presentation. I would like to introduce now Vicki Lowe and Catherine Akia with, actually, no, sorry, I've got the comment really quick from Puck, and then I'd like to introduce Vicki Lowe and Catherine Akia with the American Indian Health Commission. Puck says, centralized knowledge, any shared info and bed availability so that people could be referred to the programs that have more openings could help. And that is definitely feedback that CRIS has provided throughout this process. So it sounds like that would be a very urgent priority. And I'm seeing Elena nodding, so they're hearing us. Thanks so much, Puck.
There's definitely work with the HCA and DOH around creating bed availability, a centralized place for bed availability. It's sort of that.
It's great to hear. Thank you again, Elena, and welcome, Vicki and Catherine. We're grateful to have you here today. Vicki and Catherine are going to present on the priorities for 2024 legislative session from the American Indian Health Commission and Tribes. So I'm going to turn over to you, Vicki.
Awesome. Thank you, Jamie. I squatchy Vicki Lowe since na Stutipo New Sklyam since na New Hawk. My name is Vicki Lowe. I am Jamestown Squala, the Strong People, and Bella Coola First Nations from Canada. I'm the Executive Director for the American Indian Health Commission, which means I work on behalf of the tribes in Washington State on state level health issues. And Catherine and I want to share the work that we've been doing. It's guided by the tribes, but really working within the Washington State behavioral health system, trying to have better coordination between the Indian healthcare delivery system and the state system, but also trying to address the urgent issues of the opioid and fentanyl crisis in Indian country. Catherine, do you want to introduce yourself?
Sure, thank you. Catherine Akia. Good day. My name is Catherine Akia, and I'm a consultant with American Indian Health Commission. I use she, her pronouns, and I am a middle-aged Native woman with a lot of gray hair, though it's dark in the front, so I get to trick everybody. I'm sitting in my living room. So it's good to be here, and I'm just going to share a couple slides here. We wanted to frame it in a little bit of kind of a bigger story. Not just come straight at you with here's the bill and here's what's in it. So we wanted to go back and kind of give you a little bit of an overview of several different initiatives that are happening, and then come back to the bill itself in the context of all of this work. So it's good to be here, and thank you, everybody. Please feel welcome to I think I've got the chat up on my screen, so please feel welcome if you want to use the chat for questions during the presentation, or we'll hopefully have a few minutes afterwards as well. So just to frame it a little bit, unfortunately, one of the ways we are looking at this, we talk about behavioral health, and yes, we're talking about both mental health and substance use and co-occurring, but we also are really looking at some of the numbers around opioids to look at what's happening with this crisis, with this epidemic, and see what does that mean? What does that mean for American Indian, Alaska Native, i.e. Native people or Indigenous communities, and how can we address that? So we wanted to share some information here as of late summer. So we can see, unfortunately, the hospitalizations due to drug and opioid overdoses was increasing drastically. And when we look at actual fatalities, death and opioid, even more, you can really see the disparities when you do the age-adjusted rate. So these are some of the things that are driving us. We kept talking about kind of like, how do we talk about this story? And one of the most important things that we've heard from tribal leaders is that it's not just, we're losing people, and when we lose somebody, we lose their entire history, we lose their entire role within the community. We are losing all of their future endeavors as part of the community, whether it's to be a hunter or a gatherer or a fisher, or somebody who's going to go out and fight for sovereignty and fight for our rights in the future. And so it's really devastating to see this. And one of the stories that we looked at here data-wise was the years of potential life loss, because when we do lose people, we're losing them very young and so much younger, and it really shows the impact of what we're doing. So just unfortunately to take a moment to ground ourselves in some of the numbers and the why we're focusing so heavily in this area. So out of this work and out of all of the passion for the last couple of years and such, there have been 2 summits this year. There was a state summit and there was a national summit, both hosted here by tribes in Washington. Big thank you to Lummi and to Talela for hosting those. And so when we started looking at local issues, there were some things that came up where, like, what are some things that could really be happening legislatively to move this work forward? And one of the first pieces is to create more access to treatment through partnerships. So this could be public, private, tribal, public, private, any of those combinations to make something that works for the community, to expand those culturally appropriate services and that culturally appropriate care. So we want to take a look at that. We're looking at this idea of public or state land for tribal facilities. I think this could be important and meets some of our initiatives that we really want to move forward in several ways, right? This is both recognizing the job that tribes are doing with the work that they're doing around facilities and managing programs that help treat people, and also realizing the state's responsibility and access to resources. And we want to see those 2 come together. This third one, and I will turn over to Vicki in a second, the process is quite complicated for getting these new facilities up and going, and so anything that can be done to help streamline that process would be greatly appreciated by all the different parties involved. So we've seen, for example, permitting, tribes trying to go through processes twice. Some of the instructions around things, where the people are there, the staff are hired, they're ready to go, and they're still waiting months and months and months and months until they can actually open and serve the community. And that's not fair to anybody. It's not fair to all. We have a dire need in our state. We know that we need more places. We know that we need more facilities for people to go. We need more treatment programs, all of that. And so anything we can do to help streamline that and make it better would be really, really helpful. So we're looking at that as some fixes. And then the 4th thing on the list is a task force.
So this also came out of the summits, and really just, the tribal leaders wanting a declaration of emergency from the governor, and he's just not able to do that. And so the tribal leaders said, well, we're not going to wait. We're going to start declaring our own emergencies, and then we need a task force, and we're going to invite the state along with us to do this work, because we do need to do it in partnership. A lot of the barriers to providing care have to do with understanding the jurisdictions between tribal and non-tribal land. And again, like those the different programs working together, understanding when you're working with a tribal government and an Indian healthcare provider, what that means. So because the Missing and Murdered Indigenous Women and Persons Task Force, I see Senator Dingra here, has been so successful, we thought, let's base it off of what they did there. So the membership that we're looking to establish is 4 legislators, because there will be recommendations, and will more than likely have some recommended legislation. For this task force, we want to have a seat at the table for all 29 tribes, because they are all impacted, and we want to make sure that they're able to join in the conversation. And, you know, each tribe needs to really represent itself, because they do have their specific issues, and then the general ones that we all work around. And then both the Urban Indian Health Programs, those Seattle Indian Health Board and Neighborhood Project, serve over 10,000 American Indians, Alaskan Natives in Washington State. We're inviting the 10 state agencies that are part of the Governor's Indian Health Advisory Council, and then 2 Indigenous persons with lived experience. And again, taking from that lessons from the MMIW, that work is really centered on the people with lived experiences, the families, and the survivors. And there's even a subcommittee of them now. And I think that has been what has made that work really effective. So we want to include people with lived experience, and then invite other experts as needed. So again, modeled after the MMIW quarterly meetings, instead of making new subcommittees, we already have committees that are addressing the issues that came out of the state summit. You know, some of these committees have been in place for years. So we're taking those committees and just restructuring them so they would be part of the task force. The treatment and recovery meeting will be our monthly American Indian Alaska Native opioid response work group. And, you know, they've really been working, supporting providers and supporting making sure that the treatment that providers are offering is effective. And then there'll be a justice one. There's a lot of important issues with justice when it comes to the opioid crisis, housing, and then community and family services. And then we will continue to have an annual summit to update the state and tribal leaders on the progress of the task force. And I think that's it. Nope. Oh, do you want me to talk about these?
Sure.
And then, you know, we just had the Centennial Accord, which is the annual meeting with the governor. And so we did talk a lot. Tribal leaders really want to focus on more education and prevention. So bringing OSPI in, with Department of Children, Youth, and Families. We have the Positive Indian Parenting Program. So we want to make sure that we're really standing those up. Then there's support of the 5 tribes. There was a contingency of state and tribal leadership that went to Iceland to learn about their prevention model called Planet Youth. So those 5 tribes that attended that trip are going to be helping implement and adapt that model so that we can use it in Washington State. We're working with Representative Lekanoff. She wants to see full funding of the Drug Task Force, because that's will solve a lot of the justice issues, is having that task force fully operational. And then there's a tribal warrants bill that I think Scott introduced last year, and there's been a work group working on it to really beef it up and make sure that all the partners involved agree on what happens. What is happening in real life, though, is that tribal warrants aren't being honored outside of the reservation. So we have to figure out how to make that work. And that involves a lot of understanding of the jurisdictional difficulties. Catherine?
So now we'll get to the bill itself. We're from the 2024 Washington Indian Behavioral Health Bill. So just as a little bit of background, and when we're talking about behavioral health, we are talking about in the same sense of both mental health and substance use crises, and looking at the different parts of the law, especially that are related to involuntary treatment, but also just notification in general, other things that are happening along the crisis continuum of care, and making sure that we're coming back to some of our fundamental core values that are things like somebody who's being seen by a tribal provider, what we would call an Indian health delivery provider, Indian healthcare provider should always be considered their medical home. We want to make sure that there's care coordination going on that's coming from a centralized place, that tribal programs are seen as peers and as relevant and having all the same rights in the system as a state. And so it really comes back to that. And so in 2020, the Washington Indian Behavioral Health Act, the first one went through. It was Senate Bill 6259, and it made quite a few changes. It was really great. It made some changes around DCR notification, around recognizing historical common resiliency. There were some other pieces as well, and it was very helpful to get going. Within a few years, though, we definitely were continuing to hear some stories from people who are trying to do crisis response on the ground of things that still weren't working. Things with notification with other partners, other players, in the crisis response system and that sort of thing. And so with that, over the last couple of years, have been collecting more and more information to make more changes to the RCW. In 2023, the majority of what is currently our bill was actually put through as agency request legislation from Healthcare Authority. And it went most of the way through the process. It got all the way up into late December, but didn't actually get out into the legislative onto the list of things that had become a bill. And so this year, the delegates from the commission, which are delegates from the 29 tribes and the 2 urban programs, as well as American Indian Community Center in Spokane, voted to run it as legislation. They said to the commission, go ahead and run it as legislation. So we said, okay, great, we'll do that. And we kicked it off this summer. We went back and we looked at the language a little bit more, have tweaked a couple of things, run it by a few folks, and are putting it out there once again. So the bill itself amends the involuntary treatment section, the behavioral health services, the community behavioral health services, and the medical records portions. And I'll do a quick overview of what's in there. So starting off, we want to get more inclusion of tribal courts. So if we're imagining that whole continuum of crisis care along all these different pieces, you can imagine that there are a number of tribal programs and services that either mirror the state ones or are similar or interact with the state ones all along that way. So everything from the original reach out and hopefully de-escalation early in the process to think, oh no, things are escalating and you need more of a response, more of a mobile response, that piece of it, but you're still in the voluntary realm, all the way to something's gone terribly wrong and now there's an involuntary assessment being done, and then somebody's actually needing to go somewhere, and then petitions are being filed and somebody's actually getting into treatment, and we're going, there's a legal process. And when we're looking at that full continuum of care, there are all these places where tribal courts, tribal law enforcement, tribal programs, tribal prosecutors, tribal behavioral health providers should be involved in that process to make it run smoothly and to make sure that we can get back to those core concepts of having somebody being cared for and watched throughout the whole continuum of care so that they don't get lost in the system. So we don't have somebody pop in one place and pop out another. And unfortunately, then that's where we hear those horrible, horrible stories of people who are released onto the street with just a couple of days of medication, or nobody knows where they are, or things are escalating across 3 or 4 different systems are seeing this person, but nobody can see the big picture and know that things are escalating in the same way, and they end in tragedy. So we want to see tribal courts included. This includes tribal court orders being accepted by facilities, as well as being able to be reimbursed for those costs. So if they're participating and they're doing the same thing that a superior court would do, we want to make sure the tribal courts can get that reimbursement for that process as well, including Indian healthcare providers in the definition of providers, just to make sure that it's really clear that nobody can. Unfortunately, we still encounter some structural racism around kind of this dismissal or not seeing tribal providers and urban providers as equals in the system, and so we're still running into that sometimes. We want to put some of that into law. Also, that the tribal correctional facilities do get some of that information. This is important information to share among entities if somebody is in a place where they need extra care and extra attention. So we want to make sure that that's there as well. Tribal law enforcement inclusion. Now, this is where I know that we differ a little bit from some of the advocates across the state. Most of the tribes have tribal law enforcement that live in the community. Often a large portion of them are from the community. it's a little bit different of a different model. We're finding stories, for example, of a police chief who takes somebody to the hospital and comes back a few hours later to find out how they're doing and is turned away, and they're not sharing that information with him, or they're not. And so and they care, they really care, they're really upset, they want to know what's going on, they're the point of contact for the family. And so we want to make sure that tribal law enforcement is inserted in all of those places that would make sense for them to be getting notifications and such. The next thing is a tribal right to intervene in crisis proceedings in state court. So if the process is going through state court and not tribal court, very similar to Indian child welfare, there's a right to come in and find out what's going on and intervene at different levels as necessary. And then also notification of tribes when a member is in state prison and being discharged. So one of the most important pieces we heard from people who have been doing this quite a while, who all the way back to what are they called, CDMHPs, and I don't know what the acronym was for, who were talking about when it did go well, what worked well? What worked well when they knew somebody was going in for a treatment of some sort and they were involved from the get-go in discharge planning. They knew ahead of time what to expect. They knew where they were headed in treatment, and they had time and access to that information to get ready for them coming back to the community. So they could get housing ready, they could get medications ready, they could get family support ready. That's the kind of things that we want to see. And so we want to make sure that those doors are open communication-wise to make sure that that can happen. 7, ensuring access to cultural treatment. We just want to make sure there's no denial of access to cultural treatment or any spiritual treatment practices. This can mirror some of the language in some of the facilities, and we want to make sure that that's just out there and acknowledged. We want to codify the crisis protocol process. So right now, tribes, there are different levels of on paper instructions for tribes to the different state entities about what they should do in a crisis. So how do they access tribal land? Who do they notify when they come? What if it's voluntary versus what if it's involuntary? How do they respond? And so what's happened is there's a template that's been created, and tribes are going to be updating their templates to be able to share with all of the different state subcontractors. So DCR agencies, mobile crisis teams, EHASOs, that sort of thing, on what should happen in a crisis, who those main points of contact are, what time can you get a hold of them, who do you call, that sort of thing. And we want to make sure that it's very clear that the expectation is that everybody follows these, that the tribes get to take a look at them and create them, and then everybody else follows them. The other thing is number 9, inclusion of tribes in state DCR protocol revisions. So I'm really happy to report this is actually already happening. This is just a matter of let's get it in writing, because right now it's happening because of good relationships. And we just want to make sure that it's always an expectation from here on out. And then finally, the number 10 is the exchange of mental health information between different providers and different entities who are in this system, who are in this part of the system. We want to make sure that it's really clear that we can get information back and forth to the different pieces to make sure that that person is getting the best care. So what we're doing right now, we finished this, we finished some of the revisions to the language and such, and it's all out there. We've been out there securing sponsorships and talking and doing lots of announcements at different things like this meeting. Thank you, everybody. And we're getting ready for it to become an official winter. So as Vicki said, Representative Lekanoff has been great in getting this going. We have a few areas. We realize that this bill is not a comprehensive fix everything. And so we have a few areas that we do realize are issues but are going to be saved for another date. Things like we want to see tribal healing to wellness courts be able to receive therapeutic court funds, but that's going to have to be a different initiative, a different project. We're looking at the assisted outpatient treatment and seeing if we need any additional language. Right now, there's basic notification language in there about notifying a tribal provider, which is great. But there's a couple other parts of the process that, I would read it and interpret it and say, of course, we don't need to put anything in here. It's very clear to me that this means to work with the tribe. However, sometimes we find that we need to add that extra language in so that it's clear to everybody else. And then the other piece is, as we have built up this relationship and are getting a much better understanding between our work groups and things like the Mobile Crisis Team Response and the DCR Association, we are finding that there's kind of a crunch point with hospitals and emergency departments, and really trying to understand a little bit better about how they work and why they're doing some of the things they're doing, like not sharing information and citing HIPAA, which we're like, no, this is the other way. You should be using it to share information, and turning people away, not coordinating, that sort of thing. So that'll have to be a future initiative. And there's a few other pieces as well.
I think Jane has a question.
Oh, yes.
Jane.
Oh, thank you. Oh my gosh, Luke, you are awesome. Thank you.
Thanks, Vicki. So I see, in terms of the chapters of law that are being amended, if the intent is to also try to apply the provisions, for example, related to the inclusion of Indian healthcare providers and the receipt of crisis services for folks that have like individual health plans, because I know the tribes do such a good job enrolling people in marketplace plans if needed, then I would be happy to have a discussion with you about language that would bring Indian healthcare providers into Chapter 4843. For example, the definition of behavioral health emergency services provider, right? Because I know back when I was behavioral health commissioner, we had lots of discussions about attestation as an alternative to licensure. And right now, the private health insurance chapters reference entities that are regulated under Title 18, so the more traditional licensure. So I'm happy to have a discussion about that, Vicki, if it would be helpful.
I think that would be great, because we do have the attestation process for the tribal behavioral health agencies. So
yep,
it's not really come up in conversations, but I bet it's impacting care.
That's a great point, because as we've had, I think we're like 3 different tribes right now that are looking at implementing tribal designated crisis responders. And as they go through and review their attestation paperwork, there's a box on there, right, for, attesting to the crisis intervention, several different crisis intervention pieces. And it was something that, maybe some of them hadn't checked that box earlier and they need to go back and double check. And so a follow-up conversation would be wonderful. Thank you.
They do that.
Catherine, is it time to take any other questions from the CRIS Committee?
Yeah, that sounds good. Yeah.
Okay, wonderful. That was a tremendous presentation. Thank you so much. And I very quickly, I just want to say how much I appreciated the way you told the story. It really kind of brought it home how we got to this place. So thank you for that. I see Representative Orwell has a question.
Thank you. Yes, great work. I have really poor reception, so sorry my camera's off. Vicki, did you talk about the expanding the Native and Strong line with text and chat?
No, but that's recently come up. And it's something we really want to make sure happens. It came from our group of tribal leaders and behavioral health program providers, that meet every month, and they really want to see that happen. So we haven't added any language to anything yet, and I'm happy to work with any legislator that's interested in that. But I'm understanding that it has to come from Vibrant, and I don't understand all those systems very well.
Yeah, I'm happy to work with you. Levi, is he on the call?
Yes.
Yeah, definitely. We'd love to add chat and text. It is a conversation and working with Vibrant and SAMHSA on that, but any work we can do locally as far as setting things up and supporting the messaging to them, that would be wonderful.
Okay, yeah, thank you.
So I know we're a little bit over time here, but I do want to make sure we take advantage of the opportunity to talk with Catherine and Vicki today. So I do have a comment in the chat. Department of Health is happy to work through the text and chat for Native and Strong 2. Would welcome brainstorming options with all. So Nicola, let's make a note of these as action items. We can put them in the summary. CRIS Committee members, let's start with questions for Vicki and Catherine. And then before we take our break, I'll check in with you about any other questions you have from the newsletter. Other questions from CRIS Committee members for Vicki and Catherine about this presentation? and the legislative priorities.
And while anybody's unmuting or getting finding the hand raise button, I just wanted to say a couple of key things we're kind of talking about around these bills and around this work is that tribes are taking care of people who are Washington residents too. To make sure that we're using that language. It's about removing roadblocks, about systems working together. It is budget neutral. We are looking at a little bit of reallocation of funds for tribal courts, but most everything else is just language. And this is just one piece of what's needed to overhaul the system. It looks big. It's not that big, I swear. It looks like a big bill because it's sprinkled throughout, but if you were to condense down the actual changes, it's not that big. There's just a lot of comma and tribal such and such comma throughout.
And Catherine, this messaging slide in particular, I think is really powerful. Would you be willing to share the slides with the CRIS afterward so that they can refer back to it?
Oh, definitely.
Okay, wonderful.
We're always happy to take more suggestions too if something really resonates with you.
That's great. Thank you. I see a question or comment from Senator Dingra.
Thank you. I just have a comment. I'll just say thank you both so much, Vicki. Thank you. It's always amazing to partner with you. Today was my deadline to finish reading this bill and provide feedback to Representative Lefkow. So I actually read it this morning. So I actually loved getting your presentation. I was like, I wish I had this presentation yesterday, so I could have spent less time reading it this morning. But thank you, and I'm very excited about this work. And we have heard over and over again how the work that our Native American community is doing serves all of Washington, regardless of any kind of tribal affiliation status. So I just want to thank you both for the work that you're doing. And I have seen and toured and noticed a great difference in how this work is being done. So thank you. And I look forward to supporting this legislation.
Thank you.
I don't see any other questions, so I just want to extend a huge thank you, Vicki and Catherine, for coming and presenting today. This is great information. We'll add these slides to what we post on the project website, but just grateful to have your participation in these meetings and always presenting really great information to us. Before we take a break, CRIS committee members, any questions for HCA or DOH from the newsletter? From this month's newsletter. Okay, I know we're a little bit behind, but I do want to give you a break before we dive into our discussion. So far, we don't have anyone signed up for public comment, so I think we'll still have our full hour for discussion. So let's take a break now and come back on camera, please, at 1:45. So that's about 8 minutes. Break, and we'll start our discussion then. So 1:45. See you in 8 minutes. Thanks, everyone. Okay, I see people coming back on camera here. Thank you so much, everyone. All right, let's get started with the discussion portion of our agenda. So our focus is going to be on your feedback regarding the summary of recommendations that you received from Nicola in an email last week in preparation for this. It's called, let me just get the title here, CRIS Committee Recommendations Draft. So it was a PDF that you received, and you were asked when you did that review to consider a few prompt questions that we're going to use for our discussion today. So the first one is, as you review the summary of recommendations, what is your feedback on how we are presenting the recommendations of the CRIS? As we hand this report off to the governor and legislators to take action, do you feel like the content conveys the CRIS's recommendations effectively? And finally, if not, what changes would you make? And before we start that discussion, I'm going to ask Senator Dhingra to help set the context for the conversation today, and talk a little bit about why these are so important and her own legislative priorities for the coming session. So Senator Dhingra, I'm turning over to you.
Thank you so much. I feel like I've been spending so much time today talking. So I'll tell you, I'm just very, very excited for these recommendations. And I'll just talk a little bit about, the first 98 bill, because I've been thinking about that a lot. And, it was really unfortunate, but in the Senate, this was a partisan vote. We only had the Democrats voting for it, and it was not bipartisan. Then all of you got involved and did all your incredible work. And when we did the trailer bill last session, it was a bipartisan bill in the Senate. And I say that because it is nice to get buy-in from as many people as possible as we do this work together. And that change from the first bill to the second bill, in my opinion, is related very much to all of you. Your engagement, you're doing the work, your thoughts, your ideas. And so I'm very excited for this recommendation because I think it builds on that work. And it gives this committee and the work that you're doing a lot of credibility, that we continue to have more and more support for this work from our electeds moving forward. And so it is very exciting. The bill, it's really, there's normally a dichotomy where people who are on task forces feel like they're finishing their work when they do the recommendations, but for the legislature, that's the beginning and the start. And so when they start their process, I just want to let all of you know that your work is not done. We would love for you to make sure you're testifying on bills. Bills change dramatically, or can change dramatically during the legislative session. And so I really hope all of you continue to stay engaged. And things can always change. So if you have an idea or something comes to you, please reach out. Don't ever feel anything is too late. We can modify, change, finesse as this moves forward. We are in a 60-day session, which is actually a short session. And so things move very, very quickly. So I am excited to see what all we can get consensus on, how it gets shaped, and what is the bill that Rep. Orwell and I will be dropping. And just know that we got a lot of kudos for doing the 98 bill in one session. The vast majority of other states did not do that in one session. So I feel like their expectations set here that we do that every year. I fully expect we will have another 98 trailer bill this session. But if something doesn't get passed, or if an idea doesn't make it into this legislative session, please know that that just means it's right for next year. So there can be a lot of emotions as we come into the legislative session. But this is a time where I really want to make sure everyone feels very comfortable emailing me, Representative Orwell, keeping everyone in the group as things move forward. And we'll try to come up with the process that we can provide as much information and update to all of you as bills move forward. But the stories that people share and the conversations we have, I know I, along with others, take a lot of notes. So there are other bills that maybe not be part of one big 98 bill that have a lot of these components. And so I do have a substance use disorder bill that staff is working on drafting, which is taking a look at removing the barriers for getting someone into inpatient treatment. And I will thank Puck and Sean again. It is really about making sure that people, even if they're clean, can get inpatient treatment. Because and I can talk about integration and medical necessity and HCA and DOH. I've heard me talk about this for a long time. But we're addressing that and really taking a look at how we can make sure you get transportation back and forth from treatment. And so it's not a huge bill, but it is a bill that we're hoping to eliminate some of those barriers. I'm having conversations on how we can do youth, the 23-hour centers like we did for the adults, and more information on that. And so I'm sure there'll be other bills. But with that, I'll just stop. And again, thank you all for your work. And please note, it is so crucial on implementing laws when we are able to get recommendations from this committee. So thank you.
Thank you, Senator Dhingra. And I don't think Senator Warnick or Representative Dent are with us today. And it looks like Rep. Orwell might have had to drop off too. So thank you for representing today. I know you feel like you've been talking a lot, and I appreciate all of your words today. So CRIS committee members, you've had some time to look at the draft, the way the draft recommendations are shaking out to be presented in that progress report that's going to the legislature and the governor's office. The steering committee wants to hear your feedback because they'll need to sign off on this. So questions for you. And Chloe, I'm sorry, I keep making you put the slides up and down. Would you put those prompt questions back up again? I just want to remind everyone what our prompt questions are. What is your feedback on how we are presenting the recommendations of the CRIS that you've been working on all this year? Do you feel like the content conveys the CRIS's recommendations effectively, particularly given that we're handing this off to the governor and legislators to take action? And if not, what changes would you make? And I'm going to open it up now to our CRIS committee to offer your feedback. So please feel free to use the raise your hand function or pop it in the chat. This is your chance to give us feedback on this. Kashi.
Thank you. I have a couple of things I wanted to mention. One is that we've been having some sidebar conversations around youth callers to 988. And part of what we identified that I want to highlight really clearly is that we still don't have a consistent process across Washington for how the call centers will identify youth callers. We met myself, some of our agency partners, the call center representatives, and national technical experts met, and we learned that it is not a federal requirement that you cannot ask more demographic information. So I would like to make sure that any references to that for federal prohibition of seeking more demographic information come out of this report so that we're not perpetuating what we had learned that was not, turns out to be accurate. Of course, the dial pad or, additional touch options, those are not allowed under federal things that I don't totally understand through, I think, the Vibrant Partner, but I want to just make sure that it is known that we actually can ask for more demographic information at the call center level. And then thus that would be something I would really like to see reflected here. I know that their questions are largely about process rather than content, but part of the reason I bring that up is that I think that relates to many other elements of the process here. One of the things I would love to see in this report is any sort of reference to dependencies about those priorities. So for example, if we can't identify youth callers, most of our data is going to be wrong, right? Because it won't tell us how many youth. And so some of these priorities that we have identified hinge upon other things in the report. And I think it would be helpful for the decision makers who are looking at these recommendations to understand where is your highest impact for changing key things, right? I think there is a huge impact to successfully identifying youth callers. Not only can we connect them to appropriate resources, but then we can gather accurate data, and that can inform more of our recommendations moving forward. And I'm certain that there are ways to apply that kind of a principle to the process of the development of the report, right? What should we prioritize that other things hinge upon that as a dependency? Thank you.
Kashi, that's excellent feedback. Thank you so much. So just to quickly summarize, remove references in the report of a federal prohibition to collecting additional demographic data, which you have confirmed is actually inaccurate. And then second, if we can be noting the dependencies so that we can see the cascading effect of different policy changes or decisions or following recommendations that might have on other recommendations. Thank you for that. Kim.
Hi, yes, thank you. I first of all apologize. I had to miss the last meeting and I think maybe even the one before that. So that's the sort of context for my feedback, but I did have an opportunity to review the current document. I mean, I think it does a lot to capture an extraordinary amount of information and ideas. So I appreciate the work that went in on that. As to the first question, I think it would be helpful in terms of how to present if in addition to giving this summary document, we also gave that, like, for example, the minutes from the September meeting that had all of the recommendations with the, people's priorities, the dots that were used, just something that kind of broke it down a little bit more so that the legislators could see a little bit more what was going on that led to that synthesis. The other main thing that jumped out at me was having been a part of the subgroup that what was it called? It was the
first responder collaboration group.
Yes, thank you. We had some really deep, difficult, good conversations in that work group about the interplay of like law enforcement versus behavioral health service provider response in a crisis. And how to, if we wanted to, and how to remove law enforcement from that equation, how to prioritize in this power dynamic, the behavioral health providers, like the directors of the scene, how to really ensure that we are only sending law enforcement in those, the rare cases when really a serious safety risk has been identified. And I don't know that I saw that as reflected in the synthesis, as I maybe haven't gone through those conversations. That's what made the deepest impact on me. And I guess I just didn't see that quite as strongly reflected. And then the other piece, there was one sort of more technical feedback I wanted to give, which had to do with towards the beginning under promoting equity, number 2, it's talking about sort of wanting to ensure people have the Bill of Rights and that they know what to expect. The last sentence I think is problematic, though. Members also emphasize the importance of an individual's informed consent. That's not the problematic part. That's true. While also considering circumstances in which consent may not be possible. Also, I think a valid point to make. But then it says, such as for individuals diagnosed with anosognosia, which I always mispronounce, a condition in which a person's not aware that they have a psychiatric condition. I just think we should cut the last part of that sentence in part because that's actually not a diagnosis. It's a symptom. It's a very controversial symptom at this point. It's definitely not a diagnosis. And it actually isn't connected to a legal ability to provide consent. So I just wanted to point that out. I can send that as an email if it's easier.
Okay, Kim. So just to make sure that I caught that you think maybe removing that "such as" phrase will solve the problem.
Yeah, I think so.
Okay. That's an easy fix for sure. And then I just want to capture, so you want to make sure that in an appendix or somewhere we're showing the breadcrumbs of how we like all of the actual recommendations and the dots and all that process. So for folks that need to do more of a dive and understand the path to getting to these recommendations, it's available to them.
Yeah, I think it'd be helpful.
And then the other point that you made is that you'd like to see more of a reflection of all the wrestling and the hard work that your example was the first responder collaboration work group. But, certainly I imagine that can carry through to some of the other work that was done this year, that can be reflected in this document in a more complete way. Did I get that?
Yeah, I think so. Thank you.
Excellent. All right. And then I have a couple of chats and then I'll go to Connie. So in the chat from Bipasha, almost sure she is, but want to clarify that Kashi is suggesting we ask for age, but not required to be shared in order to serve. And I'm saying a nodding head. So yes, people will hold the right to deny any information they choose not to give, with the understanding that to use something in the system, they will need to share more information. So I think that's, yes, certainly everyone's in agreement. When people believe a program will help, they give up information voluntarily anyway. For example, when people choose to engage the Children's Crisis Outreach Response System in King County, they know we have to fill a screening form and they need to share a lot more details, and they always do. So I think, yes, we're on the same page, but thank you, Bipasha, for reaching out with that clarification. And Betsy reminded me to ask folks, please submit your specific recommendations in writing as well. And we'll reiterate at the end of this conversation what the next steps are in terms of getting to review the actual document, the full document. So, one more in the chat, and then I'll go to Connie and Linda. In response to Kim, and I'm going to mispronounce this too, so Kim, I'm with you. Anosognosia is not a diagnosis, but it's a term that surfaces a fair amount in our lived experience group. We need to have a deeper conversation about it. It's a touchy but important topic. So thank you for raising that. All right, so I see Connie, then Linda, and then Kashi. Connie.
Hi, let me drop my hand here before I forget. Excuse me. So I noticed that it includes, under promoting equity, it does include veterans. I would like to suggest that you expand that to include active duty service members and their families. I don't know for sure about the other branches of service, but I do know that in the Army, if you're active duty and you seek psychiatric support or behavioral health support, your commander is immediately notified. And yep. Yeah, I know. It seems like a violation of HIPAA, but they are immediately notified. And that information doesn't always stay private. So for active duty service members, having an outside resource is going to be important. And for the 988 operators, it's important to understand what an active duty service member might be facing or going through.
That's great feedback, Connie, and apologies for my facilitator fail by showing my feelings about what you just said so readily on my face.
No problem. I'm sure it's what everybody was thinking.
I try usually to maintain as neutral a face as possible, but that was a total fail there. But thank you. Okay, so expanding when we reference veterans, that we also include active duty service members and families, understanding.
Yes. So the acronym for it is SMVS, Service Member, Veteran, and Families.
Okay, we'll make sure we spell out that acronym so people know what we're talking. Thank you.
Sure. You're welcome.
Hi, Linda.
Hi. This may be splitting hairs, but I think it's a fairly important one, that when we're dealing with a crisis, often we don't have a diagnosis. And so I think that referring to things as co-occurring mental health and substance use disorders assumes a diagnosis. And I'd like to suggest we say issues or problems, because in detox, we see people who are hallucinating because they've had high doses of fentanyl and it goes away, or we see people on meth that are hallucinating, and that isn't necessarily a permanent mental condition, but it's certainly a symptom, and it has its own problems. And at the same time, in the mental health world, and I did MHP work in the very beginning, you often see somebody who appears to have a serious suicidal inclination, but as soon as they sober up, it may or may not have the same dominance in their diagnosis. So I think it's important that we recognize that what we're seeing is tentative and not necessarily a permanent label that the person is going to live with.
Thank you, Linda. I appreciate that. And as Alicia said earlier, words do matter. So I don't think it's splitting hairs at all to clarify. So I heard you say that that diagnosis maybe can be replaced with a word like issues or something like that.
Issues, problems, symptoms, things like that, that our work is to ferret that out.
Wonderful. Thank you. Yeah. All right, Kashi and then Anna.
Thank you. One of the things I wanted to highlight just about how the feedback is presented. Kim, I take your point that some breadcrumbs to how we got here would be valuable. Breadcrumbs being probably the wrong word, but some sort of background on how we got to this place is valuable. I do worry that 10 pages already is a lengthy summary, and I don't want our priority recommendations to get lost in the background. So I'm wondering if there's a way to do both, adding the background for folks, but potentially this is a restructure of the recommendations, and what does it take to make them actionable? Like, what vehicle do they take to be made into the policy change, or what does it take to implement the recommendation? Because if I'm somebody who needs to take action to read this is a lot to get through for me to understand what I'm supposed to do with it. And with an immense amount of respect and appreciation for our legislators, I don't know that this is what everyone wants to spend their time reading. So, if the intended audience is governor's office and legislators, how do we make this as easily accessible to them as possible so it's clear what we want them to do, right? This is right now organized in a way that is really centered on the themes we have talked about as a committee, which is really appreciated for those of us who have been a part of it. But if the intended audience needs to act, it's not clear to me based on reading this what actions we need them to take. Thank you.
I see Betsy wanting to respond to that. So thank you, Kashi. Betsy.
Kashi, did you take some time looking at the spreadsheet that outlines agency actions, legislative actions, CRIS items for 2024? Yeah, what the recommendations is really a highly rolled up synthesized version of the spreadsheet. So I think my concern would be that if we synthesized further and made it, even shorter, we would start to lose some important content. So just offering that for consideration as we figure out what to do with this.
Yeah, and I clearly make that recommendation as the person who doesn't have to make this shorter, which would be a painful role to be playing right now. And I think there's going to be an inherent tension between how do we provide enough information and how do we make this fast enough to read that it's digestible and actionable. And so maybe rather than a reduction in words, more of a restructure so that the narrative makes it clear how to act on these things.
Well,
and again,
and also,
I say that as somebody who doesn't have to redo it or
yeah,
rework it.
Kashi, I appreciate where you're going because I'm always thinking about policy, what do we do, how to make things actionable. One of the challenges we have here is that we aren't necessarily prioritizing action. We aren't as a committee saying, do this first and not this. I mean, we have, potential areas for action. I think the steering committee would probably appreciate some prioritization, but that hasn't been the process that we've gone through. So I turn it over to Senator Dingreth to respond here. It's really about what the steering committee wants and where it would like to go, and potentially for it to make those decisions about the ultimate priorities to make this a skinnier report.
Thank you for that, Betsy, and thank you so much, Kashi, because I am a huge proponent of an executive summary. So yes, we have recommendations and all of that, but if you can do like a quick 1-pager or 2-pager, which just has like the high level stuff, so if people want to read more, they can read the full report. But in all honesty, if you want the legislators to read that, you've got to make it shorter. Staff will definitely read it because they have to, but I can tell you, like, I have a folder with all the stuff that I have to read, and I prioritize it based on the issues I work on. And I can tell you many times the other stuff, I read it when I have time on the floor. So I think anything we can do, I'm a huge, I love being able to do graphs, images, but an executive summary that's really nice and short is very helpful. And the back end, you can put in all the information you want so people can flip to it and read the sections they want to read and get more information if they want to. But a quick cheat sheet is helpful.
So, and I see Anna's hand up, and sorry to jump the line, folks, but I want to respond kind of in real time. We will have an executive summary that will be essentially 2 pages. And again, it's a roll up of it's really bullet list of the recommendations. And then you can go to the content of the report. And then there's the spreadsheet that, Kashi, what I was referencing, which gives you each line item and kind of what we're thinking this means in terms of agency, legislative, or, CRIS action for next year. Again, it's not a prioritized list of, do this, not this. And I don't know if there's consideration that we want to take around that, but that's the status so far. So thanks.
And I'll just say that spreadsheet with the icons, that's really, really helpful. And I think it gives very clear direction on who's responsible. So I think when you want to take a look at accountability or does someone follow up, you can actually see where that action item lies.
So just to summarize takeaways from this exchange, to the extent possible, with recognizing that there has been some but not extensive prioritization by the CRIS Committee, any way that we can make this more digestible for people who have time to read it in very snackable chunks would be super helpful. And but acknowledging that it has been greatly synthesized down from the existing spreadsheet that was attached. And maybe more to come, since this is a short session and some of these may be factoring into future sessions. So Anna, you've been super patient. Thank you for waiting.
First of all, I want to echo what Kim mentioned about there seems to be a lack of reflection on the discussion of law enforcement. And the reason I brought it up a second time is because Jamie, when you were taking note, you had just primarily said, you know, the discussions around the first responder collaboration subcommittee. And I just want to have it on record, since words matter. We're talking specifically, I want to make sure that we pinpoint specifically mitigating law enforcement, because this was a discussion that was back and forth with the general CRIS Committee and with lived experience. And, you know, we came to a point where, you know, there was almost consensus that, yeah, we need to mitigate police response. And I am not seeing working towards that goal in any of these recommendations. I'm seeing, you know, trying to do research on why people aren't calling 988, and, you know, is it law enforcement? Well, yes, it is law enforcement for a lot of people. And I just really want to emphasize that, you know, somewhere in this list of recommendations that we emphasize mitigating law enforcement response. So that I wanted to add that. And then two, when it comes, you know, another thing, you know, we have the vision up there and we have a lot about equity, but one thing that I'm not seeing here, and again, emphasizing that words do matter, I'm seeing, you know, care to responsive to age, culture, gender, sexual orientation, people with disabilities, geographic location. Okay, never mind. I saw language on there. Sorry, I missed that. It's so important, especially as somebody that represents the API community. And that's the feedback that I'm getting quite a bit. So I apologize that I missed that, but that is something that I did want to emphasize. I also want to thank you for including the stigma, you know, including, you know, as far as the messaging goes in mitigating that stigma. And in this context here, we're referring to crisis facility centers, but I think, you know, a campaign to reduce stigma on mental health is going to help with trying to propose crisis behavioral health centers. Is going to help with 16 bed in-bed facilities. I just want to thank you and wanted to express my appreciation for making sure that we have stigma in this list of recommendations. So thank you.
Anna, thank you so much. And thank you for clarifying the point and echoing the point that Kim made. I think it's very clear now. I missed it, and I apologize that we're talking about emphasizing mitigating for law enforcement involvement, and that needs to come stronger here. Kim also thanks you for echoing that in the chat here. And Michael adds, my biggest beef, that is the main reason why we are here. So you have a lot of champions of that. It's certainly something we've talked about throughout, and it sounds like it needs to be more explicit and clear in this language to reflect the depth of that discussion. One more piece in the chat, Kashi says, an executive summary meets my request for a more digestible synthesis. It wasn't clear to me that that one would be created, so that's helpful to know. So thank you.
So Jamie, can I just for a moment clarify that what you're seeing, folks, is the recommendation section. And thank you, Kashi, for making creating an opportunity to share that the report, this is not the report. This is the recommendations section of the report. And you'll see the draft of the report on Friday, which is 25 pages, and then some appendices. So you'll see an executive summary. you'll see a section on progress in 2023, some partnership language, and then these recommendations flow, and they will also be included at a very high level in the executive summary. So that's why I'm asking specifically that if you have comments, to put them in writing. We'll include them in this draft that will be sent out for, and Nicola, I don't know if we're doing it at the outset or if we're doing, I guess it's as you review it and get us comments, we will incorporate for final review at steering committee. But all this information is really helpful, and we're happy to get it. Also, in recommendation 12, we speak to some of the work that was done in the crisis collaboration work group. I don't know that we specifically as a CRIS adopted all the recommendations that came out of the work group, but that work group work informed the discussion that we then had in September. And so if there's a recommendation that all of the content that came out of that crisis collaboration behavioral health crisis work group be incorporated as recommendations, we should know that so that we can be much more pointed in the drafting.
Thanks, Betsy. And so just to clarify, the process for CRIS committee members submitting any written feedback that they're also providing verbally today would just be an email to Nicola, and then on Friday they'll be getting the full draft. And so anything that hasn't yet been incorporated, they can add to that in the draft. Okay, great. So CRIS committee members, other feedback on the report, and then just a reminder, what's your feedback on how your recommendations are being presented here? Considering that we're about to hand this off to the governor and legislators to take action, are these recommendations being presented effectively? And if not, what would you change? And you've already done a great job of, many of you, of answering those questions. I know some of you also might prefer to marinate in this in a little bit and then send written thoughts later, and that is completely fine. That's why we created this sort of modal way of reviewing and providing feedback and listening to others. I should also note, while you're thinking about it, Carrie Waterland with HCA was not able to join today, but Tisha Kirschbaum from HCA is listening on her behalf. So Tisha, thanks for being here.
And Jamie, I have a correction from Nicola. The draft is being sent on Monday.
Oh, sorry. Yes, draft is being sent on Monday.
I said Friday. So yeah, I got a correction.
We don't want Nicola staying up all night the next 3 nights. So yeah, let's thank you for that correction. Linda.
Oh, I all of a sudden just forgotten what I was going to say. Well,
I hate when that happens. It happens to me all the time.
I was listening and then I went, whoop. I'll send you a note.
Okay, no problem. Other feedback so far? Oh, yep. Bipasha also sent a note in solidarity. I forget sometimes mid-sentence what I was saying. It always comes back. And yes, I know that feeling too. All right. Well, I really appreciate the feedback that we've gotten so far. Like I said, this is the first of a few, or like Betsy said earlier, it's the first of a few opportunities to provide feedback on the report. So if you're someone, like we said, who still needs to marinate in this in a little bit before providing feedback, that is completely fine. Looks like Linda remembered what you were going to say. Linda.
Yet I get so intent on trying to find something down below. Where is it in reactions or something that I do? Anyway, I was thinking about the detox programs and whether they are considered crisis or not. It's never very clear. And it would be helpful for, I think, legislators to know if they are considered part of this or not. Because one of the things that's in here is around capacity, and we're losing detox programs, very rapidly. And there are a number of reasons. One is poor funding. And so I just think that it's important to point out that sometimes other things are driving our capacity issues besides strict legislation. I know that the alcohol drug providers have raised the issue of room and board rate, which is pathetically low. And I think that's contributing to the loss of residential capacity.
So Linda, it sounds like if we can help clarify for legislators and the governor where there's actions that we're asking them to consider taking versus other things that are being handled in a different way, that would be helpful. Okay, great. Any other comments at this point? Okay, I have a question for you. So we shifted the process a little bit this year, as Betsy mentioned, because we heard feedback from CRIS committee members last year that the time to review and provide feedback on the report felt very compressed and short. And so this year, the approach, as you saw, was to provide you with kind of the meat of the report, the summary of recommendations early to provide feedback. And then you'll have that time from Monday, November 13th through December 1st to review and provide feedback on the actual document. And maybe this is a question to ask you at the end of the year, but just any feedback on, is this working better for you? Is there something you'd like us to consider differently for next year? Any initial thoughts on how this process is working for you? Might take your silence to mean you probably need to get through reviewing the actual document before you provide feedback. So we'll circle back with that question again. Brittany, do we have any folks signed up for public comment today?
We do not. Okay,
well, I might have a gift of time for all of you, a little early holiday gift of time. So let's pause here and talk about next steps. Nicola, can you help me out? I know we have some things that we took down in terms of follow-up from Vicki and Catherine's presentation. Would you mind just kind of walking us through what we captured for next steps?
Absolutely. So we've got sort of the follow-up on the text chat for the Native and Strong Lifeline, which is also highlighted in the recommendations as part of the recommendations coming from the tribes around the place to call. So that is one piece of follow-up. And then as far as feedback on the report, we've got a recording and we've taken notes of the feedback provided today during the meeting. We appreciate, anything you want to send us in writing this week that we can incorporate into the draft report that we will be sending to you on Monday. So next Monday, where you will have until December 1st to spend some time reviewing and sending feedback on the report. After that, we will integrate your feedback and prepare a final draft report for the steering committee to review and ultimately approve at their December 18th meeting so that we can submit by January 1.
Okay, Nicola, and any feedback that folks have before they get that draft on Monday, they would just email to you right now. Is that right?
Exactly. If you can just email it to me, I will reflect it in the draft report that goes out.
Excellent. All right. Did we miss any action items that anyone else noted? All right. Well, congratulations. It's been a very productive, very busy year for this committee. I just want to echo Senator Dinger's words earlier about how impactful it's been. Really, really appreciate the thoughtful feedback that everyone provided today. And I'm making a special note, Anna and Kim, and Michael, of the point you made about making sure it's really clear in here, the discussions around law enforcement and reducing that involvement in mental health crisis. But, and Puck and Sean, just so grateful for you today and for sharing your story. I think it really was particularly meaningful for the work that we're trying to do here. So thank you for that. CRIS Committee, I got to tell you, I just appreciate each and every one of you, and I'm so honored to be part of your process. And I look forward to more great work in 2024. Betsy, do you want to say any closing remarks for our last meeting of the year with the CRIS?
I'll just echo your sentiments, Jamie. Thank you for your diligence, one and all, for your hard work, and for making this report an improvement over last year through all your feedback and your contributions. So I'm sure we'll be talking to you as we move forward with getting the report finalized.
And if you haven't yet, take a look at that spreadsheet that Nicola sent out. It represents a tremendous body of work from this CRIS Committee. And if you have any doubts about what you've accomplished this year, take a look at that, because it's quite something. Everyone, I wish you all a wonderful rest of your 2023. I hope to see your faces again soon, and look forward to working with you in 2024, and enjoy the 34 minutes of time that you've been gifted today.
Bye, everyone.
Bye.
Thank you.
Thank you all.